My name is Fred Schaich, and we're here at the 22nd CROI here in Seattle, Washington. We just got back from a press conference that was I kind of interrupted myself and left early, so I didn't get a lot out of it. You have not given your presentations yet, and this CROI has just begun. So both of you are bringing something to the CROI, which is a discussion about Ebola, which is very important to us and our community, and you'll describe why. But we are here with Gilles and David, who did the press conference, and we hope that we can learn something today about the Ebola virus and how it's affecting HIV in the countries where there's a high prevalence, and what you know about it through MSF. I'll let you go first, Gilles.
Okay, thank you. My name is Gilles van Cutsem. I am the medical coordinator for MSF in South Africa and Lesotho, but I was the medical coordinator in Liberia in November and in December. MSF has been invited by Scott Hammer and CROI to present the MSF experience with the Ebola epidemic in West Africa since March 2013. And so that is what I will be talking about.
My name is David Leuenberger. I'm working with the Swiss NGO Médecins Philafricaine in Guinea. We've been working there for a couple of years in HIV, and we were kind of surprised last year by the Ebola epidemic. And together with our scientific partners, we have described the impact of the Ebola epidemic on HIV care in our region.
So tell us more about your presentation, Gilles, because I think it's interesting. I did hear some of it initially before I had to leave, but if you would.
Yeah, I mean, my presentation will present the MSF response in the context of a description of the overall epidemic of Ebola, and in the context of the extreme failure of the international response. I don't know if you want me to elaborate on that.
I think so, because that was what was mostly struck me, is that this could have been a very different course of this.
Absolutely. I mean, now in February we're at 23,000, more than 23,000 confirmed cases, more than 9,000 deaths. 500 healthcare workers died in countries where you already have extremely limited number of healthcare workers, completely almost destroying the health systems, having very large effects on the economy. The World Bank estimated $500 million, I think. No, it's probably more than that. Sorry. Yeah, I mean, as MSF in March, we were called by the Guinean authorities to confirm the outbreak, which we did. And by then, we already called for an international response, saying this is a different type of epidemic. It's not the usual rural epidemic. It has reached Conakry, a capital. It's already in multiple different sites. We will need an international response. Very little response by then. The epidemic actually went up in March, April, then went down. First wave. Second wave started again in June. In June we called for saying, okay, the outbreak is out of control. We have reached maximal capacity of MSF. There are more than 60 concurrent outbreaks at one time, including in the three capitals, Conakry, Monrovia and Freetown, and we need additional support from states and from other NGOs. Still very little response. In August, finally, WHO declares Ebola a public health emergency. By that time, there are more than 200 cases per week in Monrovia. Bodies are being thrown in the streets. There is no response.
So even today, we have an epidemic that is not being handled properly in some cases.
Even today, we have an epidemic that could be handled. Well, it's not finished at all. You still have geographical expansion of the epidemic. You actually, after a massive decrease in the number of new infections in Liberia and Sierra Leone, you now have an increase in incidence in Guinea again, and an expansion to new districts. In Sierra Leone, after an initial decrease, you have again stabilization at relatively high levels of transmission. I mean, there were 74 new cases last week. That's not a small outbreak. And yes, there's still insufficient community mobilization. There is still vastly insufficient contact tracing, and which is the key to reducing the epidemic. In Guinea, 17% of new cases are on a contact list. That means that 83% of new cases, we have no idea where they were infected. As long as you don't have all the cases on a contact list, it means you don't control your outbreak. In Sierra Leone, we have no idea. They don't even have data on how many cases are on a contact list. And in Liberia, they're, well, 2 weeks ago they were at 100%, now they are at 33%, but the numbers are very small. So that's going relatively well. We still lack inter-country coordination, where you actually should share these contact lists between countries, because there's permanent traffic of people across very porous borders. And we don't have rapid response capacity as it should be. And what I mean when I say rapid response capacity is the capacity as soon as there is a new case in a new area, the capacity to put a full response of community mobilization, a treatment center, case investigation and contact tracing, safe burial, support of non-Ebola health facilities, and case, I don't know if I already said that, case investigation and contact tracing. That is the minimal that is needed to control the epidemic, and we don't have it at this point.
So, is there anything that anyone can do? I mean, we probably have organizations like Gates Foundation or Bill Clinton's efforts to address issues like this. I know you said that your resources for MSF, is there, I mean, we have Northwest medical teams from this area, from Portland, Oregon, where I live, and there's probably other resources that you can approach for other doctors to come in for an extended period of time to give assistance, but that's limited. You know, they can't spend their lives there. They can only come in for a short period of time. And that can be very expensive too.
Yes. I mean, there's an article that was published last month looking at, first of all, what happened with the commitments, the financial commitments of states and the funds, showing that only 40% of donated money has actually reached the region. So first of all, you need to make sure that the money gets there. Secondly, we still do face vast gaps in human resources. I mean, MSF has 4,000 staff on site. There's another interesting article that was published last week looking at how US academia or academic institutions are not making it very easy for people, for doctors and health staff to leave.
We've had some rather widely, I don't know, promoted through mass media that people that are vilified in their own communities, you know, and so forth. So, you know, yes, they follow a protocol, but I know we're just so, you know, concerned about the virus spreading in this country that people go hysterical when there's somebody in their community that they think might have it, even though the protocol has been followed, and they're still going a little bit overboard with that. And the opposite is true for you in those countries that are most prevalent, where the prevalence is really worthy of a concern. So it's the opposite situation. We're hysterical here about nothing, and we're leaving, like you say, bodies in the street, which is insane.
I mean, the reality is that to prevent further expansion of the epidemic, including to other countries, you need to deal with it in West Africa. As long as there is an ongoing outbreak in West Africa, it will be a threat first for bordering countries. There's now new cases just on the border with Ivory Coast.
And with healthcare workers who have to come in and then go out of the area.
Absolutely.
Yeah.
And in terms of safety, I mean, MSF has very strict safety protocols. We've had very few staff contaminated. I mean, I'm saying we have 4,000 staff on the ground, of which more than 300 are international staff that go on 4 to 6 week rotations. That is hundreds and hundreds of people who already have gone through West Africa. We had 28 infections since March, of which 14 people died. 3 of them were, 3 of the infections were in international staff, and the other 25 in national staff. You know, what that shows is that with the current measures in place, it is, what's very important also is that the majority of these infections happened in the community. So nosocomial infection in a treatment center, we think it is less than 6 since the beginning of the epidemic. It's very, very small numbers, and that should be reassuring.
Well, when you're out in the community, you don't know whether someone's infected or not. I mean, you've not yet identified that. Right?
Yeah.
So, David, the challenges you bring to the table is the co-infection issue, and how does that play out?
Well, it's actually the collateral effect of the Ebola epidemic.
It's not necessarily co-infection. No. It's just dual incidents.
Infection in the same place, kind of. Yes, as MSF has rightly highlighted, this has been a major catastrophe for the region, and the catastrophe is, of course, the direct effect. So people are getting sick and dying of Ebola, but not only. So there's been a massive effect around that, which is largely hidden because it has been described by observers, including from MSF, but it hasn't. There hasn't been a lot of data on how big is this impact. And I was actually working in a place where we were treating HIV patients in Macenta, which is the most affected district in Guinea by the Ebola epidemic. And so we tried to kind of describe and quantify the effect it had where we could measure it, which was in the attendance at our hospital. And the effect was basically twofold. In the general services, patients simply didn't turn up anymore at the same level as they did before. One effect which we did not have in our hospital was that our hospital was functioning throughout the epidemic. So an additional effect, which was in many other places, that hospitals actually closed or had less service offer because either they turned to treating Ebola, or the staff fled, or the staff had died, or so on. So that was not the case in our hospital, only I think because of the support our hospital had from our organization. But what it shows is that there was a massive fear in the population, which made them not seek health care during this period. And what we could measure is that we had a 50% drop in new HIV diagnoses during that period, a 50% drop in new TB diagnoses. So all those people were forgoing treatment, and presumably many of them have actually died because of that, although we could not measure that. Of HIV or TB or many other diseases, malaria and maternal and surgical and so on. So we are pointing and trying to quantify something which is hidden in the community, but which is a vast problem. So beyond Ebola, many people are dying from preventable causes, simply because the whole epidemic has massively affected the healthcare system in general.
Mm-hmm. So I see this as an extraordinary drama. Is there anyone that's covering this from just from a health perspective as well as maybe documentary? Because this is something that should not, as you say, not be. It should not be this way. We have the ability to do what we know we need to do, what you know we need to do, what you know we need to do. And yet, we don't have this maybe well reported. I mean, I feel like I'm learning something here that I didn't have an idea of. I had no idea that we were still in a point of despair and inappropriate coverage of healthcare for the situation. I feel like that isn't getting out.
No, what is true is that you have had a tremendous amount of press around
here in this country,
but mostly focused on expatriates being on the few 19 international infections in
and there are
Europe
people that
and the
won't
United
fly
States.
on an airplane because they're fearing this Ebola. When in fact, I think Tony Fauci said it right at a Cure meeting. He was going on his way to testify on the Hill. I don't remember the numbers, but he says, obviously, if you want to be worried about something, be worried about the flu. Influenza. How many people die every year? They die of influenza. You can take a shot. Yes, it isn't totally protected, but it is but there's where you could have your fear placed, but not in the one chance in a million. You'd be better struck by lightning twice in the same day than get an Ebola infection.
Absolutely.
So there is this absurdity, and yet this, on the other score, almost dynamically opposite, equally different, and yet different on the other score of ridiculous not attention in the case, which is where it's actually coming from. It's the, you're not killing it at the source. You're not stopping it at the source.
I mean, you also must see that the Liberia, Guinea, and Sierra Leone, before Ebola, were already amongst the most neglected, poorest places on earth. Liberia had 50 doctors for a population of 4 million before the Ebola epidemic, which killed 15. So it killed about a third of their doctor workforce, which was already minimal. Sierra Leone has hardly more, Guinea a little bit more. Vaccination coverage for measles in remote districts was around 30%. Now I know you have recrudescence of measles in the US, but your coverage rates are much better than that.
It's almost like an analogy of a tinder dry area, just waiting for a lightning strike to set that whole thing on fire, which is what happened here. You had already a desperate medical healthcare system that then was just decimated in a matter of moments.
Yes, and I totally agree on the fact that even if we are managing to control and bring the Ebola epidemic in itself to a stop in the next couple of months, which we hope, but it's not sure yet, there will be an ongoing impact on the healthcare with all the other attending problems. So this whole system has destabilized a health system which was already among the weakest on this planet, and this will have ongoing effects. And I plead very strongly for, in addition to upholding Ebola efforts, to start thinking now about good measures to reinforce the healthcare system as such, not only to control Ebola. Because, I mean, many people have said it, the healthcare system, the weakness of the healthcare system was part of the problem. People did not trust the authorities, at least in Guinea, they did not trust the healthcare system because of its weakness, and that was part of the problem contributing to the Ebola epidemic in the first place. So it would actually be part of preventing another epidemic in the future if we strengthen now the healthcare system. And of course it would have a lot of benefic effects on all the other diseases which are out there, among them HIV and TB and malaria and so on.
In the developing world. Gentlemen, it's been really a treat having you describe this horrible situation, because it is something that has to be put out to the public. And I think to go along with that and to extend the impact that you might have apart from here is maybe if you have websites you can give me, I will put them on attached to this particular video so that we make that available as you see fit.
Yeah, absolutely. There's a lot of information on the MSF website. But you have to see Ebola as war. It has the same effect as war. It shuts down the borders. It closes the schools. It closes the health system.
The whole infrastructure goes to pot.
It completely paralyzes, and it has a massive economic and health impact. So post-Ebola, and I agree with you, David, we need a Marshall Plan, we need a reconstruction plan post-Ebola for West Africa, and
so that the next epidemic does not decimate yet further and again.
Absolutely, absolutely.
Thank you so much for your time. I really appreciate you coming over. Thank you.
You're very welcome.
You're welcome.